Hello, everybody. I'm honored to be a part of this conversation. My name is Erkeda DeRouen, and I'm a family medicine physician and lifestyle medicine physician who is board certified and really strongly interested in family and community health, as well as decreasing healthcare disparities. Right now, I currently serve as an associate medical director of a telemedicine company where I spend every day trying to think about ways and how we can decrease disparities in healthcare and trying to figure out how to merge technology to innovate. So I'm excited that we have this summit to talk about different ways in which we can address these issues to change the world. And there have been a lot of interesting conversations that were absolutely necessary this weekend. And I think it just highlights that the reason that we're here and we're focusing particularly on Black people right now is that Black people are dying. Like, we're dying due to lack of care, due to lack of due diligence, due to genetic, social, cultural, economic, and political reasons. And a lot of these systems have been in place that have caused us to have mistrust of the system. And in particular, there have been a lot of studies and things that we've talked about, and I won't go into detail because we've discussed a lot of them, whether or not they're the Flint water crisis or the fact that African Americans are 2.4 times more likely to die of COVID than their white counterparts and other things. But there has been a lot of research that when a person is treated by a Black physician, they're more likely to have better outcomes. And right now, as it was mentioned earlier, only about 5% of our doctors in America identify as Black. And those numbers have actually increased. So from the 70s, Black women composed about 2.2% of the population of Black doctors, and that's gone up to 4.4%. But now, surprisingly, Black males' numbers have gone down. So they've gone from 3.1% in 1978 to 2.9% now. So while we're talking about how to address the social inequities and the healthcare disparities, we need to think about how to impact that in the realm of the healthcare workforce.
And thanks, Dr. DeRouen, for that initial comments. Kind of want to dig deeper into that. I think there's always the easy notion that when we think about the healthcare workforce, that it's only about the physicians, right? But our healthcare workforce, as a physician myself, covers the whole spread of not just doctors, but the nurses and the technicians and the administrators and the people that are part of our hospital and health systems. Can you maybe talk a little bit about, where do African Americans or Blacks ultimately end up, or at least is it what's leading people towards one subsection of that healthcare workforce versus others, and how do we make that more equitable across all of those categories?
Absolutely. I think that that's an interesting point and is very valid. And as mentioned in our last discussion just now, we don't need to just focus on one sector. We need to be more interdisciplinary. Like right now, we're at a hackathon, and I've honestly never been to one of these pre-meetings before because I'm in medicine. Our conferences aren't typically thinking about these things, about design thinking and stuff, but it's necessary. So we do need more physicians, but we need more nurses, more EMTs, more healthcare administrators, and different people to look from different aspects. And I think that we can increase the workforce by having things like this, by having mentors, by having discussions and letting people know that there are different avenues. When I went through medical school, I didn't know that there were other ways aside from practicing in academic medicine or going and working in a hospital center or working in private practice. I work for a technology company now, and it never crossed my mind to look into those different workforces to see how we can impact change in different ways.
And so one of the points you're bringing up is having access to those right role models or those people in leadership positions. And talking to others, it's a little bit of a chicken and egg issue too, right? So if we as you mentioned, if only 4.4% make it as out into the workforce, how do we, there's the nurturing through the pipeline to ensure we have that same representation across, but then if we don't have the pull, how do we reconcile those two things in parallel, as opposed to waiting to grow the pull before we can even get that leadership, the promotion through medical school or residency and fellowship, and ultimately leadership in medicine?
I agree with you that I don't think it's necessarily like us not having the pool. It's us not preparing people as well enough to make it through the process. So there are lots of applicants that want to go into healthcare, but they don't know what to do, or they're disregarded in terms of what they can do, and kind of told not to go into medicine. For instance, when I was in medical school, for full disclosure, I had an interest in academic medicine, but on my rotations, when my attending supervisor asked me what my interests were, and I told him that they were academic medicine, he told me I should think of something else because first, I'm a woman, and second, I'm Black. So it's going to be a hard road for me. So when we have these mentors who are discouraging us to go into it, it starts there. There are great pipeline programs that start even in like elementary school and moving up, where they can do something to increase it. But the bigger issue is us getting in the room. We need more people there to advocate for you, for people who are on admissions boards where someone's test scores may not be as well as someone else's, and advocating and looking at their application and saying, wait, they've done all of this community service, they have this great work ethic, they're doing great in these different experiences, and bringing that whole person there instead of just one aspect that typically will get someone taken away from the pool.
And one of the, especially as a physician, one of the things that I was always taught is, patients tend to like being seen by people like them, whether it's their race, their ethnicity, their gender, their, what geographic area they're coming from. But that immediate sort of aspect provides that biggest trust in the patient and physician relationship. And so I wonder if you could talk a little bit about, so that really speaks to the importance of having the right representation within the healthcare workforce. But I guess on the other side of it too is, what are some ways to provide that trust without necessarily being exactly who our patient is, or vice versa, seeing the same workforce as who we are?
Absolutely. I think that medicine is diverse, and it's diverse for a reason. And of course, we can have those connections from anyone wanting like, meaning wanting like for instance, you can see just in this recent day today, Yusuf had on a Howard sweatshirt. And I went to Hampton like Angel and Rakisha. So there's that little like, oh, I want to deal with the Hampton people. But we can't always have those options. So like it was addressed yesterday on our fireside chat with April and Angel, they were talking about ways in which they were disregarded as a patient. And as a doctor, I really didn't want to believe it, because we want to think like we all took the Hippocratic Oath and we want to do what's right for our patients and our other colleagues are doing the right thing. But as a Black woman, I know that they were telling the truth, because not only have I experienced it, my family members have experienced it. And it comes to the point where there were near misses and even actual catastrophes that have happened to them, and I had to come out and pull the doctor card. And when you do that, things move. But patients should not have to advocate for themselves. Doctors should advocate for their patients. So that should be everyone. Everyone should be on board. The small subset of minority doctors is not enough. So we need to figure out a way to impact the community of healthcare to advocate for all patients and treat them equally. Bias training is not enough. So we need to figure out ways in which we can increase awareness about the disparities like we're doing right now, and hold other people accountable to influence those changes.
And it's interesting you bring up bias training. I mean, that's obviously been a more recent hot topic with what the administration's been doing. But do you think there is a place for bias training for essentially our patients. How do we get the patient population to be more accepting of a diverse workforce that we're trying to achieve, or a more representative workforce?
I think there's a lot of to do in that realm. And like we've said, like there are reasons that certain populations do mistrust the healthcare workforce. And I think that these conversations are bringing up even bigger conversations and having doctors check themselves to say, am I being biased? Like, is this me? And it's a good conversation. Like I've had some of my very dearest Caucasian friend doctors texting me over the past, since 2020 has erupted, to say, hey, I'm talking to this patient and they're accusing me of being biased. Would you have done the same thing? And I think that that's a great thing to be happening. Like, check yourself. But I think from a patient side, they practice what you preach. You can't, like, be a good doctor, showcase them, ask them about themselves, learn about their environment, see how you can help, get out there in the community and work to solve these things. If you feel like a patient is being quote unquote non-compliant and not taking their blood pressure medication, for say if they have hypertension, ask them why. A lot of times it won't be just because they don't trust you and taking the medicine. They may live in a food desert. They may have to decide between buying their medication or feeding their family. They may have side effects that they didn't feel comfortable because they were kind of disregarded when they told you, hey, I'm having headaches, hey, my legs are swollen. Like, listen to your patients and talk to them as human beings, and you may learn something from each other and build that trust.
So maybe we'll take some of the questions from the audience here. The first one is, how can we best utilize peer support specialists, a person with lived, quote unquote, lived experience, end quote, who has been trained to support those who struggle with mental health, psychological trauma, or substance use, working in an interdisciplinary clinical team to mitigate racial disparities?
I think that you can use that lived experience, like I said, to just connect with people as human beings. Like, it's okay to tell someone, um, I know this because I've been through it. And it's not necessarily like playing like tit for tat, like saying, oh, I had it worse than you, or I know exactly what your lived experience will be. But it's showing that connection so you can work together to develop a plan with them and build that trust in the community. And of course, you're going to use evidence based medicine to do what is right for the patient and send them through the appropriate mental health pathways or even connect with them. There are a lot of patients reaching out, especially now in the current racial climate of 2020, as well as, like, on top of that, they're dealing with COVID and other things and along the way that are looking for mental health providers of color. And there's a shortage. So aside from bombarding a lot of African American mental health providers who are more than happy, of course, I know, to accept patients, but you can also say, like, I may not have lived this experience if you're not of color, but I understand and I empathize with you, and tell me how I can help you.
So we've talked about sort of recruitment of the pool into the healthcare workforce. We've talked a little bit about the pipeline of the healthcare workforce, at least progressing through. And I guess I'm also kind of curious about the aspects that turns people away from medicine to begin with, first of all. So, whether it's the financial literacy, being lured to private sector or industry jobs, but maybe even to the aspects of things like burnout and the mental health perspective, or even the large amount of stress that's now been happening with the healthcare workforce due to COVID. Have you seen anything, whether that's been more exacerbated because of racial inequalities or?
Absolutely. I think that there are a lot of barriers to Black people even getting in the front door in medicine. And
Mhm.
with that comes other things. So there is discrimination in the medical education system. There are financial barriers, and some people are a little discouraged if people are leaving. I think the average amount of medical school debt is over $200,000. So if you're coming in with additional debt from undergrad and other responsibilities, you may be discouraged through that. There are some systems in place like the National Health Service Corps or the military who may help do some incentives to decrease your loan burden. But some people are discouraged by even seeing the numbers, so they don't even want to try, and they don't have the financial mentors due just to our structural systems of the economy to help give them a roadmap in order to invest in themselves and their education. There are things you're talking about, the COVID crisis. I think it was even mentioned yesterday within specific cities. Um, Black people are dying at higher rates. We're dying at 2.4% more times than our white counterparts in COVID. And a lot of our doctors who go to serve who are Black go back to their own communities and serve. Those communities have less resources. They may have had fewer masks in the beginning of the crisis, and some of them have died because of the lack of resources for them serving their community. There is a burnout system. So if you are the only person in the room, there are a lot of institutions where there's only one Black person there. For instance, my company has 300 employees, and there are 6 of us that are Black that work there. In my medical school, I think there were over 200 people in my class, and I think there were 14 of us. So when there are smaller numbers, you may not feel as comfortable coming forward with the issues that you're dealing with mentally and the stresses, or feel like you have that support system, which may lead to further burnout.
And so we're almost running out of time, but maybe we can end on, if you could pick, 1 or 2 top pain points or problems that you would want the hackers to focus on in a few weeks at the hackathon, what would those areas be for developing, whether it's a tech solution or an awareness campaign or a nonprofit or what?
Those are great questions. I can think of a billion, but I know that we don't have time, so I'll just name a few. One would be like, how can we leverage technology to increase the amount of Black students accepted into medical school, whether or not that's helping with study skills or navigating the process? How could we hack technology to decrease the loan burden? And how can you also increase access to attractive and competitive rotations? So a lot of our doctors go into primary care or OBGYN or something like that, but we need more Black dermatologists out there. We need more Black surgeons and people who look like us so that the patients can go and see them. We need more GI doctors, as we've seen with Chadwick Boseman. We are dying earlier of colon cancer, and our numbers, we're supposed to be screened at age 45, but some doctors don't even know that, and they're screening them later at the age where the average American is screened, and we're dying later because the cancers are found later. So there are a lot of things to hack, but I think it should start with getting more doctors out there.
Well, thank you so much, Dr. DeRouen, for your time today, and that will go on to the next session.
Sounds great. Thank you for having me.